background noise is coming, sir.
From my side.
Fan. Yes, sir. Any fan or anything is off, sir? Which is
No.
No. Okay, sir.
It's actually it's very quiet. Maybe there's some static thing is going on, no? Some sort of background noise.
Yeah, sir. I don't know. I'll just mute myself, sir. Whether it's from me, I'll just.
No, it is not there.
Sir. So I think it is from me only. I'll mute myself.
Okay, then you're right. No, I think it's okay. Yeah, when you are talking, that static is coming.
Okay, sir. Sir, we'll wait for 2-3 minutes, sir.
Definitely. Whenever you are ready, you tell me.
Okay, sir. Okay.
Oh.
Hello, sir.
Yes.
Sir, I think 30 people have joined, sir. Slowly, I think everyone will come.
Okay. So we will start.
We can start, sir. Yes, sir. Yes.
So good morning to you all again. And what about the exams?
Sir, date has been declared. 27th August it is.
I see.
Yes, sir.
Can you hear me properly?
Yes, sir. Voice is clear, sir. Yes.
Okay, right. So on your right hand side, there is a very famous iconic book by Bernard Shaw, The Intelligent Woman's Guide to Socialism and Capitalism, which is considered a path-breaking book, non-fiction. So he is one of my most favorite authors. That is why I have taken a liberty to use that terminology, that intelligent residents, because all residents are intelligent. So they should have some guidance only to approach an examination as well as adult congenital heart disease. And then I have added some few often asked exam questions which may be of relevance, which probably would have been already discussed in your clinical discussion with your teachers, but still we will see whether it can be of use. See, on your left hand side top is Robert Gross, who did the first PDA ligation in 1938, and on your right hand side is Gibbon, who invented the cardiopulmonary bypass, which made open heart surgery possible. So these two people are really great people. And at the time when Gross did the first PDA in 1938, of 100 congenital heart disease, only 10% reached 18 years. Whereas now in 2020, it's almost 95% reach adulthood. So that has been a great turnaround, and that has made this what you call as an adult congenital heart disease. Now, the adult congenital heart disease has a new name also, which is called, as you know very well, they will ask you in the examination, grown-up congenital heart disease, otherwise called GOOCH. And of course, if you actually look at the Oxford Dictionary for the meaning of gooch, you may find that that meaning is not very what we call as it's not a very fine a word used in colloquial English, but that is another point. Anyway, what we will do is we will go through this adult congenital heart disease. Start with the basics, evaluation and management principles. And this grown-up congenital heart disease, the term was used by Jane Somerville, who is supposed to be the congenital heart disease. She is from UK. So the Europeans use this term gooch, whereas the US people use still the term adult congenital heart disease. They don't fancy using the gooch, but in the examination, the examiner can ask you what is meant by gooch in cardiovascular system. Now, we have data mainly from US on adult congenital heart disease. And in 1965, you can imagine, like 35, 50, half a century ago, of all adult people living with heart disease, basically 70 were unoperated, only 30 were being treated. Whereas slowly, now what has come in US is that more than half are actually operated or a cured or a palliated procedure. So now and another thing is that now in US, adults with congenital heart disease outweigh the number of children with congenital heart disease. That is not so in our country, but it has changed, and slowly it may change. And especially in Kerala, from my state, it may be definitely going towards that direction. Now, the adult congenital heart disease will have three subsets. One is an unoperated congenital heart disease. Nothing has been done. They are what are called the natural survivors. Some of them are surviving because they are minor lesions like a small VSD or a tiny PDA or a mild valve PS. Some of them are very complex like an Epstein anomaly or an LTGA, but they survive because of their hemodynamic advantage, which we will see. Then you have the second group, which is called surgically altered congenital heart disease. It's not repaired completely, surgically altered. For example, we have done a BT-shunt, things are okay, they are lost to follow-up, they are remaining. Then we have what you call a situation where you have operated completely repaired conditions, like simple conditions like a ductus, or a definitely treated condition like a tetralogy of Fallot, who may be there. So we have actually three subsets of adult congenital heart disease, as you know very well. Now, this slide is very key to your examination, because congenital heart disease, which will be diagnosed in the adults for the first time, there are four most important conditions. One would be ASD, because they can come in the examination as a case. Epstein anomaly with or without palliation can come to you. An LTGA with either a VSD, PS or a left AV valve regurgitation can come to you. And you can get an adult coarctation also in the examination. So these are all very important conditions for you to know that this is the first time these conditions may be diagnosed in adulthood. Now, the cardiac issues in general for an adult congenital heart disease, especially operated ones, would be the problem with the ventricular function, the problem of heart failure, the problem of a residual shunt even after a surgery, then vascular problems and valvular problems. For example, AV canal defect operated will have a significant MR. Then a very, very important condition, arrhythmias, because it could kill the person. And a very important, 50% of our population belong to the female of the species. So pregnancy, I think, is a very important issue in relation to cardiovascular problem in adulthood. And of course, we will have non-cardiac issues, that is how much of sports one can enjoy. Can they get pregnant, and if they get what kind of contraception to prevent pregnancy if necessary. Then genetic counseling, very important, because more and more young women are are having operated heart disease, which were not initially operated. So they will get their children. And employment, insurance, and then of course the standard, in any major hospital you will find people for a anesthesia fitness for what you call as a non-cardiac surgery. So we have to tackle all these problems. And when you assess for a non-cardiac surgery, you must naturally assess the saturation, X-ray, ECG, echo, blood count, etc. And generally, you should know, people can ask you which are the adult congenital heart diseases which are high risk for a non-cardiac surgery. It would be any person who has significant pulmonary hypertension, any cyanotic heart disease, especially with pulmonary hypertension. Prior Fontan is not a very good disease. Complex congenital heart disease. Then a congenital heart disease is an arrhythmia like an Epstein with a documented SVT. And of course, a post-operative or pre-operative congenital heart disease with ventricular dysfunction, especially the systemic ventricle. And how do you evaluate any kind of adult congenital heart disease? Is by clinical evaluation, pulse oximetry, ECG, chest X-ray, echo. And then, of course, as and when indicated, you should do a cardiac MR, ECG, catheterization. And sometimes you will read an electrophysiological study also to pick up arrhythmias and you treat them. And after the post-basic evaluation, the standard things, you need a combination of triad sometimes. These three combinations, that is echocardiography, MRI, and catheterization. And this is very important nowadays. People can ask you a theory question on MRI. And so sometimes people even feel that CMR is an alternative thing to echocardiography, or it could be a second method and it has some superiority over echocardiography in terms of volumes of the RV, because many of the post-operative congenital heart disease are having an RV issue. Then PR in tetralogy of Fallot surgery, RV contive, pulmonary artery and aorta, all those things are important for a adult post-operative congenital heart disease, not only post-operative but a pre-operative congenital heart disease. So it is increasing utility and is an adjunct to echocardiography and of course replacing catheterization in complex congenital heart disease as well as in adult congenital heart disease. But you may sometimes need actually catheterization to resolve the anatomy and the physiology and plan of course for an intervention. And of course, in an older people, adult congenital heart disease, planning to undergo some procedure cardiologically, you may need a coronary angiogram also. So this is also a very important entity. Then once you decide that the child or an adult may require some sort of a therapeutics, which could be a medical, for example, treating heart failure, arrhythmia, thromboembolic episode, pulmonary hypertension, and of course an acute infective endocarditis, or it could be an interventional or surgical. And exercise, I think, is very important. You may assess formal testing, a TMT can be done, can be a dynamic exercise can be offered, but a strict, very aggressive activity exercise is non-compatible with an Eisenmenger, severe PH, univentricular heart, coronary anomalies and severe Epstein. But you must understand that post-Fontan, some degree of physical activity has to be allowed, because one of the mechanisms by which there is a forward flow to the lung in a Fontan circulation is by skeletal muscle contraction and pumping of blood into the pulmonary artery. And medical, as I told you, treatment of heart failure, arrhythmias, pulmonary hypertension, and infective endocarditis. And the definitive treatment for an adult congenital heart disease could be either a surgery or a catheter intervention. Both can be for prior palliation, prior repair, or even a primary condition. And of course, sometimes you may require a hybrid procedure. Now, with this basic background, we will start with various clinical scenarios. This I know, you know that this is George Bernard Shaw, probably the second greatest dramatist of all time. Now, this is a girl who had recently become symptomatic as dyspnea and fatigue. has occasional palpitation. There is no cyanosis. Saturation is 94%, tantalizingly 94%. Pulse is normal. Blood pressure is normal. JVP is elevated with a prominent A wave. There is cardiomegaly with an RV apex. RV apex. S1 is normal. S2 is split wide with a loud P. S3, and there is only one murmur, that is a 2/6 ejection systolic murmur at the pulmonary area. And what happens is that the X-ray is taken, little depressing X-ray for a lady like this, because there is hardly any cardiomegaly, but there is severe pulmonary hypertension. As you know very well, almost looks like a rat tailing, and also there must be severe pulmonary hypertension. ECG shows, as you can see here, a slightly peaked P wave, normal PR interval, right axis deviation, and there is still an RSR pattern. There is a small, very small R in V1. So we will think of a second ASD who has developed severe pulmonary hypertension. Echo is done, large ostium secondum ASD, still shunting left to right in spite of that particular X-ray. RV systolic pressure is severe but subsystemic. There is still RV volume overload, and there is no pulmonary stenosis to protect the pulmonary artery. And this is a transesophageal echo is done. Now the question is, go directly for a transesophageal echo or do a cath or intervene is the question, and what kind of intervention. So they did a catheterization. The basal on air shunt was surprisingly not bad, 1.8:1. PVR was 5. This is again okay. And the ratio, PVR-SVR ratio was 0.4, which is slightly on the higher side. And oxygen was administered, and dramatic increase in the shunt, reduction in the PVRI, and reduction in the ratio, SVR ratio. Overall looks promising, because even the basal shunt is more than 1.5. PVRI is less than 6. A ratio is slightly more than 0.3, which is the accepted norm. But on oxygen, she has done very, very well. And as you know, the current operability criteria is that QP/QS in a shunt, irrespective of the level of the shunt, should be more than 1.5:1. PVR should be less than 6 Wood units, and the ratio should be less than 0.3. Little more stringent criteria compared to the old criteria which we followed when we did our DM. So based on this, she was definitely offered a device closure, and successfully, and post-procedure everything was fine. So that brings us to the second commonest congenital heart disease overall, and the commonest congenital heart disease in adult practice. And as you know very well, we have three major our triad of auscultatory finding in an ASD: wide and fixed split of S2, an ejection systolic murmur at pulmonary area, and of course a mid-diastolic murmur at the left lower sternal area. And in a child, the impressive systolic murmur can be unimpressive. You should concentrate mainly on the S2. And very simply, a well-split S2 on a standing child is likely to be abnormal. Think about an ASD. And sometimes I have seen in a child, the MDM can be even louder than the ejection murmur. That is a very important practical point in a child. And another practical point is that ejection systolic murmur will be maximum 3/6, 2 to 3/6. Thrill is extremely uncommon. This is a standard exam question. That is, what are the causes of a thrill or a loud murmur at the pulmonary area in an ASD? Usually with additional pulmonary stenosis, or with an MS, which we call as Lutenbacher, or with an MR, because all these conditions with PS, with MS, with MR, you are likely to get case presentation in your examination. Or sometimes a very huge ASD with a torrential flow also can produce sometimes thrill. But these four answers, you have to be very, very clear about these answers in the examination. And ASD in an adult will present with, as I MR, And during pregnancy, chest X-ray showing cardiomegaly, symptomatic, embolic stroke, atrial fibrillation, and heart failure. Fatigue will be an important symptom. And of course, arrhythmias can occur after the third decade. Now, this is another very important practical question, not only in live, also in examination. Why an adult develops worsening in an ordinary atrial septal defect? One, progressive pulmonary hypertension develops. Second, from the fourth decade onwards, atrial fibrillation will set in. Third is the continuous volume. See, RV is, of course, is happy to handle volume, but it has been handling volume for 30 years and naturally they will feel a little tired. So they will go into an RV dysfunction. Then in adulthood, because 25% of adults will have hypertension, some of them will have coronary artery disease also, which will reduce the compliance of the left ventricle, which means more of blood will shunt into the right side. And of course, some of them will have an associated mild MR or a MVP with MR that can progress. They can have a rheumatic hematologic disease which can progress. And lastly, of course, coronary artery disease itself can worsen the symptoms. So these are the standard answers for why an ASD worsens in adulthood. And standard thing, JVP A is equal to V, but in the presence of a severe pulmonary hypertension, you have a wave which is prominent. And another practical thing which is asked in the examination is that in spite of having no pulmonary hypertension, many ASDs will have a loud, prominent P2. The reason, one is that pulmonary artery is dilated and is more anterior than usual. And then there is a particular property of the pulmonary artery in an ASD that is called a brisk elastic recoil. I think that terminology is enough for the examiner. They will be very comfortable with your answers. And another practical things. MDM, usually a right-sided murmurs increase on inspiration, but in ASD, the MDM does not increase naturally because of the same reason why there's a fixed split in S2 in ASD and no RVS3. Because usually in a large VSD or a large ductus, you will expect a LVS3, which actually is followed by an MDM, whereas majority of ASD, you don't get an S3. And if you get an S3 in adult ASD, it may mean an RV dysfunction, because RV is very used to handling volume, so there will not be much turbulence in the RV side. Now, you may get a combination in the examination with PS with ASD. How will it change? One, JVP, A wave will dominate rather than A being equal to B. Thrill, as I told you, systolic thrill indicates that there may be a pulmonary stenosis. An ECG will show an R pattern rather than an RSR pattern, and a loud ESM. Wider split of S2, because usually PS also will have a wide split, ASD will have a wider split, and P2 will be soft. So you must understand that if we have a regular adult ASD, in spite of no PAH, the P2 may be little on the louder side. But if you have a soft P2 with an ASD, you should think, are we dealing with an additional pulmonary stenosis, especially when you have a systolic murmur or a loud systolic murmur. Now, another question in the examination which they can ask you is that when you have an ASD with cyanosis, developing cyanosis, what are the possibilities? The standard possibility, of course, is Eisenmenger syndrome. Some of the ASDs will have an unroofed coronary sinus, which can produce a desaturation like 90 to 94, etc. Then PS develops, severe PS develops, and then produces a right to left shunt. And of course, a large eustachian valve and direct IVC blood to the left atrium. These are all the standard answers to this particular question. And majority of an adult ASD can be devised and with a zero mortality. And surgery, of course, can be offered with a very small mortality. And this study, I think you must go back to Moss Adams and read this particular study's discussion in the ASD chapter. Murphy et al. Did a very huge study on a post-operative ASD and showed that the survival at 30 years depends on age of surgery and presence of pulmonary hypertension. You can see here, if you do surgery in an ASD below 24 years and if the PA pressures are almost normal, you have a near normal survival compared to a controlled population. So this Murphy study is very, very important. People can ask you about this. And also it's very important because you will have an adult ASD for a case discussion. So they can ask you what is the survival, 30-year survival for a older person like 28-year-old man with a mild to moderate pulmonary hypertension, compared to controlled population, it is still good, but it is not as high as 94. It is only around 80. So this is a very important study. You should read sometime before your examination. Then post-procedure, follow-up, residual shunt, RV size, PA pressures, arrhythmias, regular follow-up every 2 years, that is enough for an ostium secondum ASD. So that is one area. So this is one particular area where you can have the most common congenital heart disease in adulthood presenting with PS or without PS, with PAH or without PAH. So do we have a question answer session now or not, 2 sessions later, scenes later?
Yes, sir. So some doubts, sir.
Yeah.
So that you told ASD NDM doesn't increase in respiration.
Yes.
And there is no RVS3, sir. We didn't get the reason, sir. Can you just repeat, sir?
Okay. See, RV, as I told you before, it's been designed to handle volume. LV is not designed to handle volume. So if you have equal shunts, 3:1 shunt in an ASD, a VSD or a PDA, what happens is that LV is overworked. Why? Because LV has to pump blood into the aorta and it has to handle blood coming from the left atrium. So invariably, what S3 means that either a large amount of blood is going into the left ventricle or normal blood is going into a dilated ventricle, right? Abdominal ventricle. So in a large VSD or a large PDA, LV is getting a large amount of blood, and you will get an LV S3, which will be followed by a mid-diastolic murmur. Whereas the right ventricle has been designed to handle volume in a large amount without increasing pressure or any turbulence. So what will happen is that the RVS3 usually will not occur in a large ASD unless they develop right heart failure. Now MDM, what is the reason for MDM? The tricuspid valve because of the left to right shunt. And as you know very well, there is a reciprocal change happening in an ASD across ASD. For example, if you have a large ASD with the left to right shunt, during inspiration, what happens is that the blood to the right side will be more, left side will be less. So naturally, the left right shunt is little less, but that is compensated by the increase in the right side flow. Similarly, during expiration, more blood goes to the left atrium, little more blood goes to the right side as a shunt, but it is equally compensated by the reduction in the right-sided volume reaching the right atrium. So they are equalized. That is why you get a fixed split. So the same mechanism goes for MDM. That means that there is no respiratory variation with a flow. That flow across the tricuspid valve, both during inspiration and expiration, remains. MDM does not change much with respiration, and RVS3 is unlikely in a regular ordinary secondum atrial septal defect, unless there is of course a significant MR in an AV septal defect where the S3 may be LVS3 because of a mitral valve involvement.
Okay, sir.
Sir, in ASD with pulmonary, in
one
ASD
point about this MDM. Yes. Yeah, MDM with S3. Both these two statements, both are, and they are present both in Abrams and in one more textbook on cardiology, so we can feel very safe in answering like this because it is anyway given in Abrams, right? Okay, Nikhil, you are asking something else.
Sir,
No, sir,
in
it was
AST with
Dr. Arun, sir.
Yes,
sir, in
Arun,
AST with
please.
PH, is sir, in AST with the PH will get loud loud P2. Actually, in other VST and other things also will get pulmonary artery dilatation. No, why that is not applicable in VST and PDA, sir?
Oh, I see. No, I think that is the second reason because see the first reason is that PA is larger and anterior, which I agree with you is that applicable to VSD and PD also. I agree very correctly, but I think the more important reason they attribute is there is some abnormality of the vascular wall of the that pulmonary artery in an ASD. So, like just like you have a bicuspid aortic with an aortopathy, there is some tissue characteristic is little different in a pulmonary artery, and there is a elastic recoil is little different, and that is again is attributed as the cause for a apparently loud P2 in the absence of a significant pulmonary hypertension. That is why when you have an ASD in the case discussion and the P2 appears to be normal or even the softer side, you should always think of an associated pulmonary stenosis.
Okay, thank you, sir.
We go to the another scenario. Yeah. Tell me. Ask me.
Sir, good afternoon, sir. Good morning, sir. Sir,
Good morning.
In the case example which you had showed, sir, the ASD with pH, the pH pressure was around 75, sir. So,
Yes.
like in those cases, there can be a possibility of idiopathic pH also, sir. So, like how safe it is? Although the oxygen studies, like they showed that there was significant increase in the shunt and the PVR/SYR ratio decreased further. But in such cases with a baseline RVSP of 75, how safe it is to go ahead with because
And you're asking, yeah, correct, because you are thinking that the whole possibility is that of an idiopathic pH with an incidental a large ASD. These are questions because sometimes we do get patients who have got ASD and pH, and some of the cardiologists all over the world are now at least some people believe that ASD has no reason to develop an Eisenmenger. So the so-called Eisenmenger ASD or a severe pH with an ASD is not because of the shunt, but because of an associated idiopathic pulmonary hypertension, which I agree with you. We even see young children with a moderate ASD with severe pulmonary hypertension, where we feel that the pH is totally different and closing the ASD will cause harm. But as you can see in this particular basal study, so basal study is almost okay. See, you have a shunt above 1.8:1, left to right, and you have a PVR is 4 or 5, which is less than 6. And the only problem is that PVR/SVR ratio is 0.4, which currently is not a right thing. But 10 years back, that was accepted. So I think they have reasonable reasons to. But this is a tricky. These are all tricky situations because you look at the X-ray, you don't feel operating, right, or doing a closure because it looks small. There is a rat tailing, but ECG shows an RSR pattern or an R pattern. So I think that is why every cardiologist, pediatric cardiologist, feel that the decision on operating on a large shunt, especially ASD particularly with a significant pulmonary hypertension, should be offered only after assessing the age, the symptoms, the X-ray, ECG findings, clinical findings. I know these are all very, very, very important. Cardiac size, that's also very important. I agree with you, but this particular patient, there was probably no dilemma, but there is always a dilemma in closing an ASD with a severe pH. And one factor which could probably make us do this closure. Maybe it is only subsystemic with a BP of 110 by 70. 75 is only a severe subsystemic PA pressure. So possibly we could offer them. And the mild gamble, this was actually done in Amrita, and they were very happy that the small gamble they took paid off because.
Okay, sir. Thank you, sir.
Agreed? I mean, agreed means you get the point? Yes.
Yes, sir. Yes.
Now, this is a lady, a 26-year-old lady who is symptomatic, who has come with a saturation of 94%, and they have done a study, pressure and oximetry study, and this was actually done in the 1960s in All India Institutes, and because it has historical importance, I tell you why. SVC saturation was 68, RA was 85, RV was 84, PA 85, wedge was 93, LA is 94, LV is 94, aorta is 94. Mean SVC pressure is 10, RA 8, V 7, mean 4, RV is 30 by 0, and diastolic 6, PA is 32 by 20, mean of 22, and mean wedge was 13. I have not mentioned the A and V. LA mean was 13. They have entered the LA presumably, and LV pressures are normal, and LV end diastolic is 5 millimeter of mercury. Saturation is 94-95, and this is the data. So this was done in 1960-61 in All India Institute, was published as a case series. So what is this lady having?
Sir, there is a
PAPVC, sir.
PAPVC. See, SVC goes up to 85 RA. So it is around a 17% step up. PAPVC can never produce such a huge step up because one pulmonary vein, nothing. Huh?
Just a ESD.
There is an ASD and there is a gradient across the mitral valve. So this is a classical example of this was one of the first series by Dr. Tandon, this team from All India Institute. After 7 cases, I suppose, were studied, and this was a classical Luton-Backer syndrome with a large ASD with a very good left-right shunt, and there is a gradient across the mitral valve producing mitral stenosis. So ASD with MS is a Luton-Backer syndrome, first published in 1916. Now you can have a case discussion in the exam also, because you can have severe MS with a small ASD, they will behave like MS. Mild MS with a large ASD, they will behave like a large ASD. The problem comes when they have both are important. For example, both ASD and MS are important. What happens? This is the standard, which I think you already know these answers, but still ASD will try to ameliorate the MS finding. For example, it decompresses LA, pulmonary venous hypertension is much less. So invariably symptoms of dyspnea, orthopnea, PND, episode of pulmonary edema is less. And of course, mitral valve calcium is also less. So this is the influence of ASD on MS. Now, this is the influence of MS on ASD. It accentuates ASD logically because it increases the left-right shunt. It can develop right heart failure early. AF will become early because, AF usually occurs in the 4th decade. This can occur a little early. And the first thing, most TMs, second MASD usually will not have infective endocarditis, but they can develop because of the mitral valve disease. And naturally, features of fatigue will be there because MS will produce a reduction in the stroke volume, and ASD also will produce a further reduction in the stroke volume of the LV. So you can have fatigue. So you should know both the effect, that is ASD on MS and MS on ASD. there was a story, apocryphal story, when Dr. C.V. Raman got his Nobel Prize for Physics, and one of his Raman effect was actually done on alcohol, ethyl alcohol. So he was given a reception in London, and they cheered him, they toasted and all. He said, "We know the effect of Raman's effect on alcohol, but now we want to know the effect of alcohol on C.V. Raman." And he, of course, politely declined, let's say. So something like that, MS activating ASD and ASD. So large ASD with severe MS, you expect a larger heart. There will be a thrill, as I told you before, prominent PA pulsations, low volume pulses because of the forward flow is reduced, JVP is prominent, wide and fixed split with a split S2. OS, opening snap, is less prominent, and there will be a long MDM, which need not be always at the apex. It can also be heard reasonably well at the left lower sternal border, and a presystolic accentuation is also a little less. These are all described by the great authors in 1960s onwards. So the RV may occupy the apex, and the TR murmur can even be heard at the apex. And of course, they will ask you what is meant by nitrogenic Lutenbacher. You know that is a post-BMB. You can get a small atrial septal defect. So, so what happens in Lutenbacher is that ASD findings like cardiomegaly, PA pulsation, wide split will become prominent. MS findings like MDM will become little soft, opening snap can become less, and there may not be a presystolic accentuation even in the presence of an atrial fibrillation. And MDM, of course, of MS is less conspicuous. The standard question, why? The reason may be flow across the mitral valve is reduced logically because there is a significant left to right shunt decompression, and RV will occupy apex mostly. So you will. And of course, the standard question, continuous murmur in Lutenbacher occurs only in severe MS with small restrictive ASD, so that there is a gradient existing across the interatrial septum, both during systole as well as in diastole. And of course, left atrial enlargement could be there in Lutenbacher, unlike in an ordinary secondum ASD. Some PVH could be expected in a Lutenbacher. Now, this is another question they can ask you, that is, how will you assess MS in the presence of a significant atrial septal defect by echo? The standard thing which we use very quickly done is a pressure half time, which will underestimate the severity, and whereas continuity equation, which is little more cumbersome, but planimetry is good enough. So the standard question which was asked to me, because I had a long case of a large ASD with severe mitral regurgitation. So the questions were all around echocardiographic evaluation of mitral valve disease in the presence of an atrial septal defect. So you should put only one slide. I think this is one very important area people can ask questions on this. And of course, this is the RSR is there, right axis is there, prolonged PR interval is also there, the left atrium indicating a Lutenbacher. This is from original, that ECG, which I taken from that BMJ article. Now, do we stop at
sir,
this?
I have a doubt, sir.
Yeah.
Sir, I have a doubt, sir.
Yes.
Sir, the pressure data, sir.
Yeah.
There is significant step up at the level of RA. So, which means that ASD is large. Non-restrictive.
Yes.
But there is significant pressure gradient across LA and across the ASD, there is significant pressure gradient, sir. How can that be explained?
Yeah. That is LA is 13 and RA is only 4. That's what you are meaning, right?
Yes, sir.
Yeah.
Yes.
You're feeling that because there is a huge ASD, there should not be a difference. That is the reason for A equal to V in in a regular ASD, where unrestricted ASD will have A equal to V. But you must remember that in spite of such a large ASD, or at least moderate to large ASD, there is an obstruction to the mitral inflow. There is definitely a mitral inflow obstruction, and you know that the mitral inflow is slightly smaller than the tricuspid valve inflow. So blood is going from that direction, and there is significant obstruction to the mitral valve, because the mean value of 13 is probably because there is significant decompression to the ASD. So this is a well accepted phenomenon that in spite of a large ASD, if you have a severe mitral stenosis, you will have an interatrial gradient. It will be there. So you theoretically you can say the gradient is around 9 millimeter, which is a little large on this thing. But yeah, I agree with you, because then you should produce a continuous murmur and all. But this happens, and this I have taken this directly from the article. So see, many of the cath data given to you in the examination or the teaching sessions, some of them are what you call as manufactured. We ourselves manufacture. So they may not show inconsistency. But whenever you have some inconsistency, which means they are natural, like leather bags, they tell you, minor flaws are accepted because it is leather, something like that. But I agree, but there is a significant difference, but that is mainly because of a very predominant mitral stenosis.
Because there is significant gradient across the mitral valve and also the interatrial septum. So the patient should be symptomatic.
Yeah, definitely she is symptomatic. She is definitely symptomatic. She had actually, according to, I read the history, basically her history was dyspnea class 2 and more of a fatigue for the last few months. She was admitted to AIMS for evaluation. These were early times of Lutenbacher in India.
Okay, sir. Thank you.
If time permits, you should read this article from BMJ 1961 and Tandon. Now, this is another very important case discussion. 19-year-old girl who has history of a hole in the heart in infancy, improved later, then lost follow-up, and now has come with progressive dyspnea on exertion and is symptomatic. There is no obvious blue color, but the upper limb saturation is 95% and the lower limb saturation is 82%. So you know the diagnosis. This has to be
PDA.
PDA
with asymmetrization.
With a predominant right to left shunting, most likely due to pulmonary hypertension. So it is a PDA Eisenmenger, right? And this is again original data. They have done these were very older studies. That is why they did all these cruel things, right radial, left radial, femoral. Now we've done only an echo and decided on whatever decision to make. Here they have done this, and you can see that the saturation in the right radial is 95, left radial is 86, which is sometimes expected, but it will not be blue, why it is 86 above 85, and femoral was 82, so confirming that there is a ductus with a reversal. And that brings us to the very important area of a left to right shunt with severe pulmonary hypertension. The number one among them is Eisenmenger syndrome. And then you can have a regular left to right shunt with PAH, where PAH is primarily hyperkinetic. And the third one, we briefly touched upon this area where you have a coincidental congenital heart disease, usually an ASD, but disproportionate pulmonary hypertension, which we feel is idiopathic PAH with a coincidental congenital heart disease. And we have, of course, post-operative congenital heart disease. I think we have one patient who is 18-year-old who has a large VSD, operated even at 4 years, but continues to have severe systemic PA pressure. So that also is possible. And we know some history of an Eisenmenger is very, very important. In 1897, Paul Wood is an authority who has the two-part article. I think all examiners expect all the postgraduates to read these two-part article, Eisenmenger syndrome or a PH with a reversed central shunt, published in BMJ in 2 parts. I think everybody should. This is a must before the examination. It is great. It's like Taj Mahal, like it has got a great historical importance. And originally, VSD with Eisenmenger was called the Eisenmenger complex. They can ask you what is the difference between Eisenmenger complex and Eisenmenger syndrome. But now the current terminology is Eisenmenger syndrome, which was first done in 1958 by Paul Wood, which includes all defects, including complex congenital heart disease. And the definition which he did in 1958, 70 years back, continues to be good pulmonary hypertension due to a high pulmonary vascular resistance with a reversal or a bidirectional shunt at the aortopulmonary, ventricular or atrial level. And now we have a different classification of Eisenmenger, because when we were undergraduates or even postgraduate, we were only concerned with the simple and Eisenmengers. Now we divide the Eisenmenger into simple, complex, and post-surgical. Simple is either a pre-tricuspid shunt or a post-tricuspid shunt. Complex can be at the ventricular level, as you can see here, a great vessel level and others also. And post-surgical or bar palliation, various shunts like water stent ports and central shunt. And of course, post-repair for a large left duration, which can also continue to have significant pulmonary hypertension, which also would be part of an Eisenmenger situation. And this is a very, very important slide, because the Eisenmenger presentation with symptoms in the second and the third decade. But Eisenmenger is established by around 2 to 3 years. So there is a qualitative difference. You should realize that Eisenmenger does not develop by 20 years. It presents by the second and third decade. But majority of the Eisenmenger which we see in our country, they are already established by 2 to 3 years. That is the importance of intervening in a young age. And early Eisenmenger, they will ask you which are the conditions. Classically, Navi septal defect, especially with the Down syndrome, Trungus, DTGA, especially with a large VSD, and of course single ventricle. Now, this is there are 4 or 5 slides which are very important for candidates in the cardiology. Anyway, I will be sending to Nikhil, but I will just highlight the difference, because if you get an Eisenmenger syndrome as a long case, they will be asking how to differentiate clinically between these 3 Eisenmengers, ASD, VSD, Eisenmenger. Honestly speaking, you can only take 3 or 4 major differences between these 2. The others are all very soft differences. You must be realistic. But in the examination is a different situation. You may have to answer. For example, the transition into Eisenmenger is least expected in ASD, as we know very well. Age of presentation is late in ASD, much younger in PDA and VSD, the mean age. And they will ask you why PDA presents little earlier than VSD. The answer is that in a large PDA, the aorta and the PAS are directly in continuity. So the direct transmission of systemic pressure into the pulmonary artery may be the cause. We don't know actually. The gender ratio is strongly in favor of female in ASD Eisenmenger, and exercise tolerance is there for both for ASD and this thing. Syncope is more or less same, whereas hemoptysis in Paul Wood series is more in a VSD Eisenmenger. Adults sometimes do squat, actually older children do squat because they are not supposed to squat in a cyanotic heart disease, but sometimes they squat. If they squat and it is an Eisenmenger, more likely to be a VSD. Heart failure is more or less same. Cyanosis, very important, differential cyanosis in ductus. Low volume pulse is more in ASD. JVP, everywhere it is prominent, but very prominent in ASD Eisenmenger. And on your clinical examination, cardiomegaly, first very, very important point, cardiomegaly is present in ASD. Precordial activity is more in ASD. And perhaps the most important single factor which examiners are very much interested is that 80 to 90% of ASD Eisenmenger will have a wide split with a loud P2, whereas VSD will be single and PDA will be close to split or single with a very loud P2. Very, very important to know. Systolic murmurs are same. Early diastolic murmurs are same. Some people believe that EDM is more common in PDA Eisenmenger, but I think original series and TR is more prominent in ASD Eisenmenger. And on a chest X-ray, cardiomegaly, very, very important. Very prominent in right descending pulmonary artery, much more prominent than the rest. But these are all relative. You have to have 3 X-rays kept in front of you to make a difference. But aorta appears to be big in PDA. Right arch, if it is present in favor of VSD, ductal calcium. I have shown you X-ray with the ductal calcium sometime back in a PDA Eisenmenger. And QR in V1, very, very important. Why? Because QR in V1 in PAH means you are dealing with a suprasystemic PA pressure. That can only happen in ASD. You don't expect a QR in V1 in VSD Eisenmenger and PDA Eisenmenger because RV pressure cannot exceed LV pressure. And arrhythmias are more or less same, maybe a little more in ASD because of the atrial involvement. So ultimately these tables are very impressive, but still ultimately the key differential points are age of presentation, the gender ratio, squatting if it is there, of course, differential sign-on, cardiomegaly, precordial activity, S2, very, very important, and TR murmur. And of course, in the evaluation, aortic size, cardiomegaly, ductal calcium, QR in ECG, and small q in V5, V6 may be found in a large PDA with Eisenmenger. And Eisenmenger various problems, I will not go into those details and all. We have polycythemia, coagulopathy, hemoptysis, all those things, and medical issues are there in terms of activity, procedures, air travel, pregnancy, which we will discuss again, employment also. Commercial air travel, very important because, basically the pressurized cabins are there, but it is at 70,000 feet level. So there may be hypoxia, avoiding dehydration and preventing DVT during air travel. And phlebotomy sometimes may be needed only in symptomatic and only when the PCV, it's not PVC, it is PCV. Because if you do indiscriminately, there is a risk of iron deficiency, which can produce a stroke. And the therapy, very well than much me, because we see now less and less of Eisenmenger. And you have what you call as a non-targeted medical management and a targeted medical management with the sildenafil, bosentan, and sometimes warfarin also. And as a survival, there is a huge study from Sri Chitra by my 1-year senior Saha and Pramod Jaiswal, who had done an excellent study on survival of Eisenmenger. And the most important factors determining survival in Eisenmenger is the basal saturation, RA mean pressure, and history of syncope. There used to be a time when we used to compare the survival of Eisenmenger versus idiopathic pulmonary hypertension. And but here this is basically only, it's not versus, it is only it's a wrongly labeled. 8 to 10 years survival is 80% for Eisenmenger, 20 years survival is 60%, whereas a 10 year survival for idiopathic pulmonary hypertension we used to say 20%, so it was easy to remember. That is 10 years survival for Eisenmenger is 80% and 10 years survival for idiopathic PH was 20%, opposite. So we will ask what is the importance, that difference. But now this 20 has become 30 because of the advent of targeted therapy in idiopathic pulmonary hypertension. And this is the data. So as you can see here, up to 50 years, things are okay, 80% survival. But beyond that, I think survival comes down. But the point is that even at the end of 10 years, 80% of people are living with a reasonable comfort in Eisenmenger syndrome. So that was the third scene. Shall we? So this was the introduction to Eisenmenger. We will have another Page percentage. Yeah, please. Yes.
Sir, I have doubt, sir. TAPVC can go to Eisenmenger, sir.
TAPVC.
Yes, sir.
Yeah, TAPVC can go into Eisenmenger, definitely. But the point is that a majority of the TAPVC will have no what do you call chance to become an Eisenmengerized. Because if you don't do anything, the 1 year survival is only 10%. They would die of either pneumonia. Actually, most TAPVCs will die of pneumonia or severe heart failure. They don't have enough time to develop an Eisenmenger. So during my 3-year study in Sri Chitra, we had seen one TAPVC which presented in childhood with severe pulmonary hypertension. That is the only case I can remember. They can theoretically develop. Louder? Clear?
Direction of shunt, how it will be.
No, it is not the direction of the shunt. It is actually the PVOD developing. PVOD developing because of the huge flow in unobstructed TAPVC that will produce further acceleration, and they will develop because anyway in the new infant itself they will have moderate pH, and with some all TAPVCs are inherently obstructive. So which also will increase the PVS, and the combination will produce a severe pulmonary hypertension. And that I agree with you that may not classically come under the purview of the definition of pulmonary Eisenmenger syndrome, because there should be a right to left shunt. Here anyway it is pulmonary hypertension. PVOD become inoperable. They can do, but very, very rare. That is why I deliberately did not mention TAPVC as a cause of complex Eisenmenger syndrome. Can we go further? Nikhil, my moderator?
Yes, sir.
Yes.
Yes, sir. Yes, sir.
Yeah. This is another girl, unfortunate girl, who had again hole in the heart in infancy and was on medication, later lost to follow-up, returned at 18 with progressive dyspnea, with a definite saturation of 83% with an elevated JVP, all the features of severe pulmonary hypertension, including early diastolic murmur at the pulmonary area. As you know very well, if you get a Graham-Steele murmur with 2L, you should remember, very important in the exam, Graham-Steele murmur at pulmonary area in PAH, the PA systolic pressure is approximately above 70 millimeter of mercury. So it is a very, very specific finding for severe pulmonary hypertension, which is a clinical point in the examination. And this child had, this girl had no cardiomegaly, oligemia with PA dilatation, pruning of the peripheries, and echo showed a large ventricular septal defect. There is hardly any cardiomegaly, and ECG was showing right ventricular hypertrophy. This is Blassie, who was at the age of 16 developed an Eisenmenger with a monophasic R wave, and the problem is that here is the situation, you know, basal is not good at all. Oxygen with oxygen also is not very nice. So she was considered to be an Eisenmenger, because if you operate on this particular person, they can die on the table. It is better to leave, because 10-year survival is around 80%, and 15-year survival is around 77%. So she was branded as an Eisenmenger. But the only problem is she married a pastor, and he against medical advice, and she came at 24 weeks of gestation. The question was whether termination, which is not possible under the current law. So she had to continue pregnancy. So that is the situation here. And you should know, whenever you have an Eisenmenger standard question, pregnancy, see, because many of the Eisenmengers you can get in the examination hall will be female of the species of the childbearing age. So there will be a lot of questions on management of Eisenmenger in pregnancy. And you should know the maternal mortality is half. Half of the 2 people will have Eisenmenger with pregnancy. 1 lady will die, and there will be a very high incidence of fetal demise. So at this point, they will ask you if you have a congenital cyanotic heart disease with PS or with the PAH, who will do better in pregnancy? The answer is pulmonary steno. So a severe tetralogy will fare, or a Eisenmenger will fare poorly compared to a severe tetralogy of Fallot in pregnancy. That is one important point, practical point to remember, not only in the examination and real life also. And the management principle would be try to prevent pregnancy by preventing marriage. Of course, they are all now currently, I think, with all these partners living together, all those things, there are situations where you have to counsel. Contraception is very important. Antenatal care, rest, stranded drugs for this. Modified drugs, for example, bosentan have to be stopped because it may be teratogenic. Hydration, lateral position, oral hygiene, travel, all those things are important. And admit beyond 20 weeks. And there are some issues on anticoagulant also. And this particular lady was hospitalized till delivery. Bed rest was given low molecular weight heparin. And 34 to 35 weeks, I think at 35 weeks, she had an elective LS by an epidural anesthesia in SAD hospital, and newborn echo was normal. And the pre-discharge saturation was 83. So this was one of the other 50%, the hope and not the agony of an Eisenmenger. And there are, of course, many issues you should read. Ways it should be a vaginal delivery or a LSCS. Both have their advantages and disadvantages and should be invariably planned, this thing. Vaginal delivery itself should be planned, and second stage has to be cut short. And postpartum very important because many of the deaths happen in the peripartum area time. So diuretics, inotropes, and stay in ICU, preferably in a cardiac ICU for 72 hours, and then 2 weeks at least in the hospital because they can have late death in post-delivery situation. And new drugs, of course, are sildenafil. Bosentan is not a drug. So pregnancy, as you know very well, high-risk situations are, very well that Eisenmenger, severe AS, ejection fraction less than 40% aortic root dilatation, and any cyanotic congenital heart disease. And you should be also aware of a car risk for congenital heart disease and pregnancy based on NYHA saturation, prior cardiovascular event, ejection fraction, and LV outflow obstruction. This you should always go and read up this thing. And there are again issues: cardiac ICU versus OBG ICU, vaginal versus LSCS, regional anesthesia versus general. These are all discussion points. So pregnancy, because anyway, one of the best chapters in Bangalore, as you know, and examiners are very fond of, is pregnancy in heart disease. Chapter has to be very thorough with this, and of course you should go back and read at least one review article on Eisenmenger in pregnancy, and that is that. So at this point, again, this is they basically to highlight the management issue in pregnancy. So whenever you get a potential Eisenmenger in a childbearing age lady in the examination, the questions will go more towards the management of pregnancy in Eisenmenger, and not only Eisenmenger but also in other complex congenital heart disease. Shall we move ahead? Silence is the answer. Yes. Yeah. This was a similar case. It's a 23-year-old boy who had a congenital heart disease diagnosed at age infancy and was on medical follow-up. And he developed a moderate AR. And because they developed a moderate AR, it is a VSD. So VSD was closed and aortic valve repair was done at 10 years and has come back with significant murmur, with a wide pulse pressure and a median sternotomy scar because of the VSD closure and the repair of aortic valve, and a 2/6 early diastolic murmur. And the echo showed a huge LV with a normal ejection fraction, no VSD. VSD patch is intact, but unfortunately the child had developed a a moderate aortic regurgitation, and the diagnosis was close to VSD, moderate AR. The solution for him was, of course, aortic valve replacement with the St. Jude, and the BP at 1 year was normal. And the echo, look at this, 65 had become 45, and the child hopefully lived happily ever after. But still, the point is to highlight that you will get a short case presentation sometimes with a young child who had a median sternotomy scar, operative case with a moderate AR clinically, and they will be asked questions on VSD, natural history, etc., etc., etc. So I think that is very important. And once you diagnose a VSD in a child, auscultate the mitral area for an MDM, you know that, aortic area for an EDM, pulmonary area, split second sound. Very, very, very important in pulmonary hypertension, because there is a dictum by the cardiologist is that if you have severe PAH in the presence of a large VSD, if you are able to feel that there is S2 is split, it is still operable. I think that is a dictum, clinical dictum, which has stood the test of time. And EDM in VSD, how do you get? One AR, another one you can get severe PAH, Eisenmenger PR, or sometimes VSD can be associated with a bicuspid aortic valve, and that can produce AR. So 3 reasons why we should get an early diastolic murmur. And we know very well, these are all very simple things, perimembranous VSDs and muscular VSDs close, the other 2 do not close. And the practical point is that the chances are related to size, and 90% of those who eventually close, they close by 10 years or so. So adult VSD can be an operated VSD with absolutely no problem, operated VSD with a residual shunt, or AR, small VSD, large VSD with PH, and of course unfortunate cases of an Eisenmenger VSD. And the treatment for an adult VSD, majority would be surgery, and sometimes if you have a very nice muscular large VSD, they can also put a device on this particular person, and of course have to be followed up. You will have this, another very, very probably one of the most important case presentation for you as far as exam and real life is concerned. This is a 24-year-old male patient who was admitted. These are all real people admitted with the progressive dyspnea for the past 1 year and increasing blue color of lips. He was diagnosed to have a cyanotic heart disease, and the surgery was done at 9 months. Second surgery was planned, but the patient was lost to follow-up. And he is severely symptomatic, clubbing with 77% saturation with a prominent JVP. Apex is showing in the 5th space. S2 is single, hardly any RVOT murmur, and no continuous murmur. I think this is the usual thing which you get in a severe adult tetralogy of Fallot. And X-ray showed a mild cardiomegaly. Aorta was prominent. ECG showed RVH. Echo showed a large subaortic VSD with severe RVOT obstruction. Gradient was 100 millimeter. BT shunt was not working. That was the BT shunt which did not work properly. And there was LV enlargement also, because in an adult adult tetralogy of Fallot. So this is the commonest congenital heart disease in adult. Why? Because the survival is the best in this patient, and they will have atypical physical examination findings, which are very crucial for the exam going students. And I think I have shown you the survival when we discussed the surgical management. That is, 1 year survival is 65%, 10 year survival is 25%, which means 1 out of 4 tetralogy will still live up to for 10 years. But 97% will die by 40 years. We should always read the natural history of most common congenital cyanotic heart disease before the examination. And he has episodes of severe headache, which lingers on, has blurred vision also. PCV is very high, 68 with a hemoglobin of 18. And platelet count is also on the lower side, which we expect. And you should look for an iron deficiency and think of a therapeutic phlebotomy because of the symptomatic PCV. In an adult, it is very simple. 500 ml you remove and 750 ml you give saline. Very simple. And iron supplementation and sometimes transfusion. in the examination, they will ask you a child with cyanotic heart disease, any child, how will you calculate the amount of blood to be given for this, to be removed from this child? This is the formula, that is the current PCV, whatever it is, optimal PCV, which is 55%, and divided by current PCV into weight in kilograms into 8 ml. So suppose the child is 20 kilogram, PCV is 70, 70 minus 55 by 70 into 20 into 80 will be around 350 ml of blood to be taken out, and around 500 ml of blood of saline to be given. Because I remember at least 2 occasions I have seen when I was sort of as a skilled assistant to the examiners have asked this particular formula, which is actually not found in adult books, mainly in the pediatric books like OP Guy and all. And various problems. Louder?
Sir, in adults, sir, will remove 500 ml, sir.
ml, yeah. 500 ml and take in 750 ml, adults. 570. So, but this answer, immediately after this answer, they will ask you, what about a child? So, you should be mentally prepared for that question also. And the solution for this particular patient is definitely surgical repair. But, it is repair, but not a cure, because it has been a long time. But definitely it will improve the life and quality of life, and mortality, of course, will be high, because the average mortality in India is around 2 to 3%, but this risk will be up to even 10%, but you should take this. So you will get an operated tetralogy fallow either by a shunt like this or an ICR, and survival of a repaired tetralogy, 30 years survival is 90%. There was 2-3 years back, there was a survival study on ICR on TOF in NEJM. And this practical question will be asked in the examination. The click you will find in tetralogy fallow. Usually it is an aortic vascular click. They will ask, is it vascular? Yes, the vascular click. It can also be associated due to pulmonary valve stenosis, because 30% of tetralogy can have a pulmonary valve stenosis. And there may be sometimes bicuspid aortic valve, which can also produce a click. And then they will ask you, can you get AR in tetralogy in an adult? Yes, because of an aortic root dilatation, a previous infective endocarditis on an aortic valve, and some associated aortic valve. So these are some of the exam questions which should be there. And TOF JVP when does a JVP become prominent in a tetralogy fallow? One, if the VSD becomes a restrictive standard answer. Then in the presence of systemic hypertension, very important. Why? In an adult tetralogy, you have at least one out of 4 will have systemic hypertension, and of course in the presence of a right heart failure. Then continuous murmur in tetralogy, reason, PDA, not from the bronchopulmonary collateral. That is very, very important. Bronchopulmonary collaterals are acquired collaterals. They do not produce murmurs. But you can have a BT shunt producing a continuous murmur. Whereas MAPCAS, that is major aortopulmonary collateral, occur intrauterine. It only occurs in pulmonary atresia, not in tetralogy. So that can produce a continuous murmur. Then diastolic murmur in TOF need not always be due to AR. It can also be due to an absent pulmonary valve syndrome in the newborn, and also in almost all post-operative tetralogy fallow because of low pressure PR. Another question is that hypertension is a very common problem in adult practice. So naturally TOF will be affected. So there is good in hypertension. It is like Darth Vader, no? If there is good, there is evil in him, but there is good in him also. Similarly, hypertension, the good thing is that systemic vascular resistance increases and pulmonary blood flow can improve. But the bad thing is that RV is anyway facing systemic pressure. Now it has to face more pressure, higher pressure, and RV failure can be accelerated. So there is both. So it's sort of a balanced effect of hypertension on tetralogy of fallow. Then another very funny question which can be asked is, can tetralogy develop pulmonary hypertension? Because by physiology, by pathophysiology, TOF is one end of the spectrum, PAH is on the other end of the spectrum, but it is possible especially when we do a central shunt in a palliative procedure, or even if you do a Gotek shunt, if it is a mismatch shunt, they can develop pulmonary hypertension. And polycythemia may add on to the burden. Yes. Now, this is a tricky comparison between tetralogy and tricuspid atresia, because clinically tricuspid atresia may look like a tetralogy, but you should be very much aware that tetralogy is tetralogy physiology, whereas tricuspid atresia is an admixture lesion. Very, very important to understand. So whenever they ask you what are the top physiology conditions, never ever mention tricuspid atresia in the list. We don't speak about tricuspid atresia as a top physiology. It is an admixture physiology with a restrictive VST. So why is it not called a top physiology? Two reasons. One, there is no large VST in a cyanotic tricuspid atresia. Second, it is an admixture. Everything mixes in the left atrium. So it is by definition is an admixture lesion. So the physiology is different. Onset of cyanosis very early in tricuspid atresia. Tricuspid atresia can have a pansystolic murmur because the obstruction is primarily at the level of ventricular septal defect. And very, very important, the fourth point is, I think, is very important, because generally in a tetralogy physiology, the murmur is inversely proportional to the cyanosis. Whereas in tricuspid atresia, you can have good murmur and deep cyanosis. And of course, LV apex and epigastric impulse, they are expected differences between tetralogy and tricuspid atresia. And again, try to read this. Is I think you have to pay for this article, unfortunately, but some of you have great access to all the internet. I think you can simply move through the internet. So you should get this article also. It's an old article, but it is very important, relevant for your examination, because there are so many atypical findings in tetralogy of Fallot in an adult, which you are going to get as a long case. Cardiomegaly in 1/4, heart failure in 15%, hypertension little more than that, I suppose, but it is written as 10%. AR can develop, right aortic arch, bronchopulmonary collaterals. There's a big study by Stanley John and team, and this is an important thing. So I think this is a very important area, that is tetralogy of Fallot in an adult. So I would definitely like to. I will ask you one question. This is tetralogy with a good obstruction, but murmur was only grade 1/6 murmur. We could hear. You hardly hear a murmur in a tetralogy, which has a very good gradient across the RVOT. Why is it so? Anybody?
Because of the VST that gets into the
Hello? Yes, please.
Since there is that can flow into the aorta instead of the cardiac.
No, everything is going to the aorta, but there is an antegrade flow across the pulmonary valve. So it is a severe obstruction. Basically two reasons, I think you should say. One is severe obstruction, everything goes to the aorta. So naturally, that is one reason. That is the reason why in a tetralogy physiology, as deepening of cyanosis increases, naturally murmur will become less. Any other reason? That is what the examiners are interested. What is the PCV? Is very high, What is the relationship between PCV and viscosity? As PCV increases, viscosity will also increase. And beyond 60 PCV, there is an exponential increase in viscosity. Up to 60 PCV, the relationship is upward but linear. But beyond that, it is exponential increase. So have you heard about Reynolds number?
Yes, sir.
All the postgraduates hearing this talk should read about Reynolds number, because it involves the turbulence due to causing a murmur, and the turbulence is indirectly proportional to the diameter of the vessel and indirectly proportional to the viscosity. So in a tetralogy, adult tetralogy with very severe cyanosis, Reynolds number will be lower. Only when the Reynolds number is more than 2000, you will get a murmur. So sometimes in adult tetralogy, you will not get any murmur at all. But on echo, there will be significant pulmonary stenosis, what we call as an antegrade flow. So Reynolds number is a very important entity which you can read from most adults. And you should know the clinical differences between a childhood tetralogy and an adult tetralogy, and you can use the data on Velour of the Velour study, and preferable to read the Velour study by hook or crook or whatever. Okay, I think many of you must have read that article. Now we have a simple case, adult case, but can be kept in the examination. I have seen this case kept as an, it's actually a lady. It was here. It is a, the description is of a man who had a heart disease diagnosed in infancy, was lost to follow-up, has come back with progressive dyspnea and palpitation, has significant murmur, and has a 2/6 continuous murmur and an MDM at the apex. So if you have a wide pulse pressure also, so things are relatively easy. You have a diagnosis of a ductus in an adult, very unusual situation in Kerala nowadays, and he had this particular X-ray, and there was a book PDA, and because he was a 32-year-old with a significant clinical PAH, the shunt, the assessment was done. Unfortunately, thing was okay. CQP by QS basal was 3:1, and PVR SVR ratio was 0.25, and PVRI is standardizingly 6. So I think this could be closed, and it was closed by a device. So PDA in an adult can be a small PDA, moderate PDA with pH, which we have seen, and it can present as an Eisenmenger, and the treatment for a operable, this thing would be device, not surgery, because some of the ductus can have calcification. So all adult PDA should be closed by device, not by surgery. And very interestingly, some of the adult PDAs, possibly because of a long-standing LV volume overload, even if you close the device with the device or surgery, they may have, some of them may have LV dysfunction, which is a very interesting phenomenon in a post-PDA ligation situation. And another question they can ask you in the examination when you get a PDA or a RSOV, because when we discuss the differential diagnosis, they can ask you which are the situations where PDA is more common in infant. One, of course, standard answer is maternal rubella. Second standard answer, prematurity. Third answer, very important for if you say high altitude, baby is born in, baby born in Ladakh, and now they have a higher incidence of ductus, and of course perinatal hypoxia. There was a study from Denver, Colorado, which showed that there was a definite increase in the number of ductus in the Colorado area. So that is a simple thing. And another practical thing, which is I think not very important clinically, it's a simple problem with some larger issues nowadays, because a bicuspid aortic valve has now follow-up is very important. Additional lesion has to be looked for, and iotopathy has looked for. We now see many bicuspid aortic valve without any obstruction, or AR with a dilated aorta. So there is an iotopathy, and basically whether we should give IE prophylaxis because in a bicuspid aortic valve with AR, because currently according to 2007 guidelines, we need not give IE prophylaxis. And of course, bicuspid aortic valve with aorta, yearly imaging, I think it is advised, not only for a bicuspid aortic valve, but for the aorta. And there are indications for a Bentall operation, as you know very well in the theory. So these are all some issues. And one practical issue is that AS and paradoxical split. See, this is very important. A2 is delayed naturally because of two reasons. One is increased LV ejection time. LV has to pump the entire blood into the through the narrow aortic valve into the aorta. That definitely increases the LV, I think. And the incisura also becomes little later, and you have a longer hangout interval. So both will produce a delay in A2. And what happens that and sometimes it can become paradoxic. But the point is, the practical point is that I don't think many people have appreciated this paradoxical split. Majority of a severe AS, you will get only a very close split of S2 or a single S2. And there is one literature saying that there is a correlation between LV systolic pressure and paradoxical split. You need to have an LV systolic pressure of around 200 millimeter of mercury. Suppose you have a BP of 100, so 100 millimeter, 120 millimeter gradient will produce a paradoxic split. This is another question which can be asked by the examiner, and they will have in standards. I think you know, apical mid-systolic murmur due to AS versus an apical MR conduction is important. Audibility of S2 is important, and the AS murmur will increase to post-ectopic. And treatment option for an adult and a young adult is balloon. Older adult, as you know, you are much familiar with this. But most important thing is read about aortopathy in a bicuspid aortic valve. Now, this is another person. This case discussion will come definitely in the examination. A 23-year-old patient who was operated at 8 months for tetralogy with a transannular patch, was doing very well and had some residual murmur. Of late, he has dyspnea and palpitation. Saturation is 96%, midline scar. JVP is elevated, cardiomegaly with an early diastolic murmur over the pulmonary area. So X-ray was like this of that particular patient, and ECG showed a RBB pattern. So this was a post-operative tetralogy with a CT ratio of 56% with a QRS width of 160 millisecond. Very important to notice this. And echo showed a normal LV function, dilated RV with a free PR, and there was a significant TR also, and the PR, this is not moving anyway. So MRI was done, and it showed a hugely dilated RVOT and a poorly contracting right ventricle, and CT imaging was also done, and the solution was a surgical pulmonary valve replacement. Previous patch was removed and pulmonary homograft was inserted, and when and what depends on the RV's end-systolic volume. Very important. MRI, very crucial. They can ask you a lot of questions on role of MRI in post-operative tetralogy management, and nowadays people are even going for a percutaneous replacement of the pulmonary valve, which is very expensive. So does PVR help? Definitely yes. In all situations, it will definitely help. So there are 6 problems of post-operative tetralogy of fallow. Easy to remember. 2 PR, most important with RV enlargement, RV dysfunction, residual VSD, residual RVOT obstruction, much less common currently, arrhythmias and sudden cardiac rhythm. So you can remember, top ones are the first 2 ones, less common is the second 2 ones, and dangerous ones are the very dangerous ones are the arrhythmias and sudden cardiac. You know, anyway, 30 years survival is almost 90%, and the 2 killers of operative tetralogy would be a sudden cardiac death and RV dysfunction following a PR. You must be very, very, very this. So this is a post-operative tetralogy with the significant PR, because you know basically the clinical PR murmur is not very loud or long, and only 2/6 PR murmur. So you are likely to underestimate the severity of PR, not only clinically, even by echocardiography. So you must be aware that MRI is the standard choice of assessment of this thing. And I told you about the QRS duration of 160 millisecond. Can anybody tell me why I am very particular about that?
So it is criteria for PVR.
Yeah, because if it is more than 140, there is a higher chance of a sudden death also. It's possible. So you should. So it's a very simple tool. See, for example, they can ask you if you have a case discussion and you are given an X-ray ECG of a post-operative tetralogy of fallow. They can ask you Are you more interested in ECG or X-ray? You should say ECG. Why? The answer is that you're looking for a QRS duration. So that is a very important point. Now this was another boy, younger boy, who went to Vigaland. Vigaland was basically in Ernakulam. It's a new name now. Water theme park had a prolonged episode of palpitation. Diagnosis of SVT was made and terminated and referred to us later with 91% saturation with a prominent JVP, cardiomegaly, wide split second sound with a murmur. And this was the X-ray. You know, from the X-ray classes, you know, this has to be an Epstein anomaly with ECG, which some of you are familiar with, in Epstein anomaly. And Epstein anomaly, as you know, 15% of Epstein anomaly can have WP syndrome, which can produce a re-entrant tachycardia. MRI again shows a Epstein anomaly, and you know, this was a AVRT. Now this particular question they can ask you, Epstein, the 3 phases of cyanosis. For example, in the newborn, you have a severe suppose you have a severe Epstein. Newborn will have systemic PA pressure. Because of severe pressure, systemic pressure, there will be a right to left shunt across the ASD and the child will be blue. Later, what happens is that the pH resolves. RV systolic pressure falls. RA mean pressure falls. So there is no right to left shunt. For some time later, cyanosis goes away. For several years, they will become reasonably comfortable. Then in late childhood, RV function starts deteriorating because nowadays people consider Epstein not only as a tricuspid valve disease, but a form of RV cardiomyopathy. So RV function decreases, RV EDP goes up, again you have a right left shunt. So this question can be asked in the examination. How do you explain the 3 phases of blue color in Epstein anomaly? And JVP can be sometimes normal, sometimes it can be prominent, A, especially in the associated obstruction, V in severe TR, and if there is a right heart failure also. And the third space pulsation, very important pulsation in cardiology, because there are only 2 major conditions which can produce a third space pulsation. One is Epstein anomaly because of a RVOT dilatation, and second is an endomyocardial fibrosis, where there again is due to RVOT dilatation. And TR murmur can be heard even to the left of the sternum, little more towards the apex, and no change with the respiration. And the split would be wide, need not be fixed, P2 may be soft, and a minimal change with respiration, and in a WPW syndrome paradoxical because the RV is activated early. And this is another, this was when we were DM students, this question was asked. Nowadays it has been taken away from the textbooks, but it used to be an interesting study where we did both the intracardiac ECG and pressure data from an Epstein. For example, if you put a catheter into the RV and take an ECG from the RV, it will show RV ECG and RV pressures logically. Then you reach the withdraw into the not arterialized, it is atrialized RV. You will get an RV ECG because it is RV, but pressures that will be of a RA. Whereas RA proper will have both RA ECG and RA pressure. I think for the last 2 editions of Moss Adams, it is not there. But sometimes this is an interesting question with an interesting answer, so you should be aware of that. And this particular patient is on a beta blocker. It can be a candidate for an RF ablation if it continues to have problems and all. And complications, we know all these things. And another practical question, exam question, is that when we suppose we are discussing a long case or a short case of an Epstein, they will ask you this distal displacement of the tricuspid valve is called the anomaly. So this kind of anomaly need not be restricted to Epstein anomaly itself. It can occur in LTGA, it can occur in atrioventricular septal defect, and it also can occur in pulmonary atresia with intact septum. This is a catch question in the examination. Adult complication, I will not go into the detail, majority you know very well, and corn operation, which we have already discussed. So this is another very important case because you will get either an adult Epstein without surgery or an Epstein who had a Glenn surgery or some surgery was done in an Epstein. So you are likely to get into this picture. Then we have only 25 minutes. I will go into quick these things. We will have an adult patient with LTGA and significant left AV valve regurgitation. So sometimes they may look like a MR, severe MR in an adult population. There may not be even cyanosis. Why? Because there is no VSDPS, only a left AV valve regurgitation. So you can get a case. So you should remember that uncorrected LTGA in an adult can have adult presentation as simple VSD with PAH, VSD with PS, which will behave like a tetralogy of fallow, and left AV valve regurgitation, MR like. Once in a while we mistake it for a rheumatic MR, and we get surprised by echo, and sometimes they will come with a complete heart block. And whenever you remember, whenever you have a dextrocardia with situs solitus, dextrocardia with situs solitus, and a TOF-like situation, think of an LTGA VSD PS situation. And you know LTGA RV occupies apex to the left, and LV is not palpable because it is behind the sternum. Ascending aorta is palpable. A2 is very loud, so it may mimic a severe pulmonary hypertension. So actually the patient may be having an LTGA VSD PS situation with a loud single S2 at the so-called pulmonary area, and this can be diagnosed as an Eisenmenger VSD also. So sometimes there are limitations to clinical cardiology. One such example is this. We can mistake it. S1 would be either soft or normal. S2 is often single. Ejection click can be due to an aortic dilatation, which is much more anterior. And of course, various murmurs of VSD, PS, and MR radiating to the left sternal border. And that is that LTGA, you should mentally expect a patient in the examination. This is another child which could come to the examination. This child had possibly a subarachnoid hemorrhage with an ejection click, suggesting a coarctation, and after stabilization showed a gradient of 50 across the upper limb and the lower limb. So naturally coarctation with a berry aneurysm rupture and MRI showing a clear-cut coarctation. Of course, in this particular patient was a balloon and stenting. That is okay, but most importantly, this is a coarctation, means a stenosis of the descending thoracic aorta with at least a peak gradient of 20 millimeter with an upper limb hypertension. And they can present in shock in the newborn, heart failure in infancy, hypertension, and asymptomatic in sometimes. We have intracardiac abnormalities, extracardiac abnormalities. But what is more important is that half of them will have a bicuspid aortic valve at least, and 10% will have a berry aneurysm. And the death are due to mean age of death is 34 years, and naturally, which means that an adult coarctation is present the first time in 25% of adult coarctation, David. So you can have both native and post-operative adult coarctation, and systolic BP is the important, because diastolic BP is more or less the same. So if you're finding it difficult to do a thorough BP examination, you be content with the upper limb systolic BP and upper limb diastolic BP by palpatory method, and make sure that the lower limb BP, systolic BP is more than 10 millimeter difference between the upper limb and lower limb systolic BP. S2 can be split, N2 can be loud, and continuous murmur is very rare. You can have collaterals or a very severe coarctation. Very unusual to have a continuous murmur. And this we have already discussed, that is the 3 to 8 posterior rib notching. No anterior ribs. Why? Because anterior intercostal arteries do not run through the rib groove. Very, very important. That is the point. This. And if the left subclavian artery is caught in the coarctation, only right rib notching will be there. And if the right subclavian artery is distal to the coarctation, only left notching will be there. And the first and second posterior intercostal arteries do not participate in the collateral network. That is why you get only from 3rd to 8th posterior ribs. This I think you know very well. That is, AR may mask weak femorals in a a coarctation. AS may mask a coarctation, and coarctation may not cause a weak radial even if a moderate AS is present. Intervention, standard intervention is a gradient of 20 or above peak to peak, or Doppler more than 30 with a resection and anastomosis. We will not go into details of this, but this you can remember. What are the post-repair problems? 2 R's: residual or recurrent coarctation, residual hypertension, aortic aneurysm, dissection, intracranial hemorrhage, infective endocarditis, and development of an AS or AR independent. So it's a lifelong this thing. I will quickly go into this. So we should monitor various things. No restriction. Drugs can be given. So it's a lifelong follow-up, yearly follow-up, routine post-operative imaging, echo, look for treat hypertension, and 5-yearly MRI or CT, and sometimes annual echo is definitely very, very important. The point is that it's not a simple circumscripted narrowing of the aorta, it's a local manifestation of a generalized aortopathy, and it's a lifetime disease. It needs lifetime follow-up and may require re-intervention. It can come to you in the examination. Then very simple, quickly, RSOV can come to you. More importantly is the murmur, RSOV to RA, maximal over right sternal border and left sternal border. RSOV to RV, maximal over mid and lower left sternal border. RSOV to RVOT at the best upper sternal border. They are very loud, superficial sounding, no peaking around S2. So RSOV is a differential diagnosis of a large ductus arteriosus. Other murmur, you can get systolic murmurs, MDM, and that of a coexisting ventricular septal defect. I will skip, not very important in the exam point of view. Then this is an interesting, it's an interesting case, but sometimes they will ask you some questions. The lady was managed as an RHD MR, come with a chest pain with a LNS, a non-STEMI, and there was pulmonary hypertension and LVS3 and an apical murmur, and it had one an AVL, and laterally it showed the Q waves, and then actually that lady had, this is another lady, another child with the Al-Kappa. That 32-year-old lady had an Al-Kappa, CT angiogram was done, and they were offered a Takeuchi tunneling. So that is also possible. Then we will go into the, this is the last part. I think this is also very important. That is often asked exam questions. Adult congenital heart disease. This is not adult congenital heart disease. We often ask questions. Some I have selected. So simple thing they will ask you, like clubbing. How will you classify clubbing? You should be very thorough about clubbing classification, and that is you have to take it from Braunwald. Braunwald has a reference of JAMA reference, and various textbooks, various clinical textbooks will give different kind of grading of clubbing. Never do that. Take the classification only from Braunwald, and which has an authoritative what do you call as an article in JAMA so many years back, and you go back and find out that classification, stick to it in the examination, don't waver, and you should know cardiovascular causes, lung causes, GIT, then hyperthyroidism. All those things, but I wanted to highlight that the examiners will think, no, it's time for a basic question before lunch time, and you should be able to answer clubbing. And you should know that cyanotic heart disease develops clubbing within 3 to 6 months only. 3 to 6 months only. That is very, very important, which is also given in Braunwald. Many things are given in Braunwald. Then most of them are not pediatricians, so you should know what is meant by recurrent respiratory infection. So you are expected to have at least 6 URI per year, which is accepted. URI, upper respiratory infection. But 2 or more lower respiratory infection requiring possibly admission is called the recurrent respiratory infection. And very unlikely that you will be given an infant for a case discussion, but you know that in infant, failure to thrive is defined as less than 15 gram per day increase below the age of 6 months. So you should know the definition at least. And this also, causes of continuous murmur in an acyanotic congenital heart disease. I'll just go through, because anyway I will be sending this slide to you. PDA, AP window, RSOV, coronary AV fistula, systemic AV fistula, Al-Kappa because of a left to right shunt, aortic ORA tunnel, Lutenbacher with a small ASD. Very importantly for an adult cardiologist, proximal LAD stenosis and coarctation. Chest murmur in a blue baby, tetralogy with the PDA, tetralogy with the MAPCA, supracardiac unobstructed TAPVC, pulmonary AV fistula, BT shunt, and trungus arteriosus. And this again, you know all these things. I think you should go through this later at leisure. The step up at and the step up, a significant step up at the atrial level, you know, is more than 9%. And ventricular level is again more than 6%, and atrial level it is again more than 6%. Then you know how to assess suppose you get a short case of a severe valvar PS, assess symptoms, findings, severity would be on a prominent A wave, LPH, wide split with a soft P2, S1 injection collect distance, RVS for long, late peaking murmur. Similarly, pulse volume low in AS, truncated systolic BP, heaving apex. Suprasternal thrill is better than a carotid thrill in assessing severity. Paradoxically split S2, LVS4, and a late peaking murmur. Then they can ask you of a remediable dilated cardiomyopathy like AS coarctation, electrical like a tachycardia induced cardiomyopathy. Very important question, because you can have a spotter of a tachycardia mechanism, electrical TIC becomes very important. And you'll see, you will get an angio of a LV non-compaction. Similarly, you will get an ECG and LV function of a echo. So very current deficiency. Very, as you know, I think many people from Andhra and Telangana know that very thiamine deficiency can also produce severe so-called idiopathic pulmonary hypertension, which is amenable to treatment. A treatable condition is a thiamine deficiency, severe pulmonary hypertension. Then if you have a VSD with the left axis deviation, think of inlet VSD, part of an AVSD, multiple muscular VSD also. And TOF-like with the left axis, which we have already discussed in the ECG class. And sudden cardiac death, these are the 5 important conditions. TOF, TGA, LTGA, AS, and univentricular heart. Now this is important because you will have either adult TOF or a post-operative TOF in the exam. An LTGA, an AS, a Fontan procedure, post-Fontan case can be kept in the exam, or a post-Glenn, so they can ask you questions on this. And very importantly, after bidirectional Glenn, you don't see a JVP. So never say JVP is seen elevated 6 centimeter and all. You will be in great trouble. Just like when you say A is this, B is this in a complete heart block with atrial fibrillation and all this, atrial fibrillation mainly. Now these are questions asked in the examination. All examiners are very much interested in asking mechanism of a spell. So you divide the spell into 2 groups. One spell occurring at rest, spell on exertion. Mostly it is on exertion by crying. So it will cause fall in the systemic vascular resistance, which will increase the right to left shunt hypoxemia. So it is a vicious cycle. Whereas spell at rest could be due to infundibulary spasm, which can produce an abrupt reduction in the pulmonary blood flow and hypoxemia. Sometimes Perloff says that there can be a spontaneous SVT and AV synchrony is lost, so reduction in stroke volume, which can cause a spell. Some examiners are not very happy about this SVT business, so be very careful. Then management logic for oxygen, mild increase, minimal role in management of spell, niches position by carb combating acidosis, morphine reducing anxiety and sympathetic action. And possibly the only catecholamine which could be used safely in spell is noradrenaline. So these are some exam related questions, which is of course, this is the last penultimate slide.
Good to have you back, sir. Your lectures are
amazing.
And people
I try to collect those situations where you are likely to get these kind of patients in your clinical examination. And so this should stimulate you to read at least one good article on Eisenmenger, adult Toff, Epstein, something like, you understand? Fontaine's circulation.
Yes, sir. Yes, sir. Any questions from our side? I think there are no questions, sir.
Yes.
People really appreciate, sir. Go ahead.
Sir, thank you for the class. You explained about TOF patients developing PAH very rarely.
Yes.
In case of TOF with PDA or TOF with MAPCAs, are they likely to develop PAH?
Yeah, TOF with the MAPCA means you are dealing with a pulmonary atresia with a VSD. So there is no antegrade flow. So you should always make a distinction between TOF versus pulmonary atresia with a VSD. MAPCA will be present only in a pulmonary atresia with a tetralogy. That can develop. It can develop either heart failure or they can develop actually pulmonary hypertension, because the lungs are what you call as facing two sources of blood supply. So that can theoretically produce a PAH situation, and that is possible.
Okay.
Because I still remember in my exam in the 80s, in the 90s, early 90s, one child was kept, one 18-year-old boy was kept with a central shunt done for a pulmonary atresia, and he has developed a severe pulmonary hypertension. So, very tricky case. I hope that you will get a pulse oximeter now in the examination.
Yes, sir. They give, sir.
They are. It's very important actually, because all exam-going students, not only DM, DNB, we should MD pediatrics also. We should get the pulse oximeter. Otherwise, sometimes you can be in trouble, because you will feel there is a tinge of cyanosis. The examiner will feel otherwise, vice versa. So pulse oximetry is very important. Do it very properly, upper limb and lower limb. Do it, write it properly. Make sure that it is documented, so that if there is a question of you are not said that, or you are not mentioned it, something like that, you show it. So I have written it here. Very, 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 very important, because see, for example, I have seen a pulmonary atresia with extensive collaterals having a saturation of 90%. There is no cyanosis, no clubbing. So without a pulse oximeter, how can we diagnose that? Suppose I say congenital cyanotic heart disease, they will catch you, because there is neither cyanosis nor clubbing. But if you have a pulse oximetry, you can safely say, sir, the saturation, resting saturation on air is 90%. So this belongs to the cyanotic group. So you can be very safe. Always use pulse oximetry.
Yes.
Even in the
mostly, sir. Yes, sir. DNB exam, sir, we are going to have virtual cases. So there's no questions of. Yes, sir. There's no question of examining the patient actually.
Oh, then you are a lucky batch. Good. But one thing is, you should be in the theory also, no? Practical questions also.
Yes, sir. But they have included OSCE sessions, sir. Like 50% weightage they have given to OSCE kind of spotters kind of sessions, sir. So that is also like a dicey, sir.
Good thing. Dicey. But go both ways.
Yes.
You can get scores in OSCE.
Yes, sir. Sir, today we have actually Guru Purnima. We have in Hindu religion, we have we express our gratitude to you, sir.
Thank you.
Yes, sir.
Thank you.
Yes, so we are really thankful, sir. The efforts you have put in preparing this presentation. So it's really, people really appreciate that, sir. They all have messaged that sir's lecture we want frequently. We want. Yeah.
So anyway, I can leave, no? Where do
yes, sir. Yes, sir. Sir, nothing, sir. Just you press end button only.
That's all. Okay.
Yeah, sir. Thank you. Sir. Thanks a lot.
Thank you, sir.
Thank you, everybody, and well, and this is I think this is a very good opportunity for you, everybody, to pass, because virtual means that you have to be a little more thorough in the theory, and OSCE will get you good marks and all. Because I am working in KIMS hospital where the DNB pediatrics people are there, and they are every year they are getting 100% pass, mainly because some of our teachers teach them OSCE very well, and they score very high marks. So, and this must be the year where DNB cardiology should have the best of results. This is not the best of times, but for you it must be the best of the years. So, so Nikhil and the team.